Welcome to this webinar on women and girls with bleeding disorders, and thank you for joining. Currently, insufficient awareness of the unique issues faced by women and girls with bleeding disorders and lack of standards of care cause disparities in access to diagnosis and treatment for women and girls with bleeding disorders across Europe and worldwide. On behalf of the EAHAD and the EHC, we are happy and proud to present to you the following 10 principles of care, which we hope will positively impact the health, well-being and quality of life of women and girls with bleeding disorders. The first principle is to provide equitable access and quality of care, irrespective of gender. Second, timely and accurate diagnosis. Third, awareness of the unique challenges women and girls with bleeding disorders face. 4. To provide comprehensive care in a family-centered approach. 5. To include a dedicated obstetrician-gynecologist in the multidisciplinary team. 6. To educate women and girls with bleeding disorders and their families on the menstrual cycle and its management. 7. Early recognition and optimal management of heavy menstrual bleeding. 8. To provide preconception counseling and access to prenatal diagnostics. 9. To provide a patient-centered comprehensive management plan for pregnancy and the postpartum period. And last but not least, to involve women and girls with bleeding disorders in registries, clinical research and innovation. Before we will discuss these principles of care in more detail, Naja Skouw-Rasmussen will tell us what the principles of care mean to her as a patient and to the patient community on behalf of the European Haemophilia Consortium. Then Dr Michelle Lavin, hematologist at the St James Hospital in Dublin, Ireland, will explain the first 4 principles of care. She is a very active and strong advocate for women and girls with bleeding disorders, PI of the Low von Willebrand in Ireland cohort study, and she managed to reduce underdiagnosis of women and girls with bleeding disorders in Ireland. Then Dr Rezan Kadir, obstetrician-gynecologist in the Royal Free London, UK, will explain principles of care 5 to 7 on the major importance of the gynecologist in a multidisciplinary team and management of menstruation. She is one of the most knowledgeable gynecologists regarding women and girls with bleeding disorders worldwide and has conducted an impressive amount of research in this field. I will then inform you about principle of care 8 to 10, including preconception counseling, pregnancy and the major need for more clinical research. I'm a hematologist working at the Van Creveldkliniek in the Netherlands in Utrecht and PI of the PRIDES study, an ongoing prospective study on pregnancy in women and girls with bleeding disorders and its management. After our short presentations, we will allow plenty of time for the Q&A and discussion. In the panel, our fellow working group members who worked hard with us to draft these principles of care will also be present to answer questions and join the discussion. This webinar will be recorded and made available online for everyone who may be interested to watch it at a later time. I now hand over to Naja. She's also a very strong advocate for women and girls with bleeding disorders and chairs the Women's Committee of the EHC.
Good afternoon, my name is Naja Skouw-Rasmussen. I am a part of the EAHAD Women and Bleeding Disorder Working Group on behalf of the European Haemophilia Consortium. I have a long-term experience in the bleeding disorder community, mainly from Denmark and at the European level. I would like to give you a bit of insight on why, from a patient perspective, that we really need these principles of care for women and girls with a bleeding disorder. So basically, it comes down to that we need equitable care for all with a bleeding disorder. For far too long, we've seen and heard about women and girls who do not have access to the same level of care as many boys and men with a bleeding disorder. It starts with a significant delay in diagnosis, even in cases where there is a family history of bleeding disorders, or for women and girls who've actually presented symptoms several times. We hear about women and girls who are not referred to haemophilia treatment centers, and they might not get access to physiotherapists despite they experience microbleeds in their joints. Or they are not offered any factor concentrate during tooth extraction, even though it ends up that they have exhaustive bleeding for several days afterwards. A lot of it probably comes down to the historical perception that women and girls cannot have a bleeding disorder, and if they do, it will be asymptomatic. But with the more and more data we have, we can see clearly that the stories we've heard over the years are true, and they should be recognized and be dealt with a high degree of seriousness. I see equitable care as when the individual patient receives the best care and support relevant to them. Some of the key elements in equitable care is very much about the recognition and accessibility to the relevant specialist and to receive correct support. These things will only happen if both the patient and the clinicians are aware of the condition and the issues that this condition may cause. And it also requires education, a lot of curiosity to learn more about what is happening, but also awareness in the broader community about the prevalence of women with a bleeding disorder, as well as with symptoms to pay attention to. I think it's important to recognize that women and girls with a bleeding disorder experience general hemostatic challenges, as well as some female-specific ones. We know that the girls and women with a bleeding disorder will experience bleeding in the uterus, and they will have to make choices about reproduction. It is pivotal to have a dedicated gynecologist and potentially also obstetrician at the multidisciplinary team to ensure that the patient is guided at best in these situations. It's still a wonder to me how several hemophilia treatment centers are considered to be comprehensive without having a dedicated gynecologist or obstetrician at the team. Because it's not a desirable situation to have a patient as the mediator between two specialties like hematology and gynecology. It creates a lot of insecurity and potentially a lot of miscommunication clinicians between patients and clinicians. I think these principles of care can really serve as a benchmark for diagnosis and provision of care. And they really encourage education of both patient and clinician, as well as to pay attention to the psychosocial challenges that the patient might experience throughout their lifetime, as well as an emphasis on how relevant care changes accordingly to the women's and girls' life stage. So from a patient perspective, I believe that we really need these principles of care to ensure the long-awaited equitable care for women and girls with a bleeding disorder. It is a tool to raise the standard and to get a common benchmark and to really recognize that women and girls around us do not and have not received the proper care for far too long. Before we dive into specific principles, I would very much like to thank the working group behind these principles of care for their dedicated work. And I also would like to thank you, all participants, to take time out this afternoon to join this webinar, and I hope you really want to provide us some constructive feedback to make these principles as strong as possible. Thank you.
Thank you. Here are my disclosures. The first principle of care outlines the need for equitable access and quality of care for all individuals with bleeding disorders, irrespective of their gender. The current problems in this area have centred on the fact that although there is an excellent network of haemophilia treatment centres in Europe, these have largely evolved from the care of men with haemophilia. And bleeding disorders are a very diverse group of conditions that affect both men and women. Indeed, women may be disproportionately affected by some bleeding disorders due to gynecological bleeding. There is also a lack of focus on women and girls with bleeding disorders and standardised approaches for their care and management. This was highlighted in the 2019 survey from EAHAD, which identified that 42% of participating European centres lack management strategies for heavy menstrual bleeding, and almost 60% do not offer combined gynecology and haematology clinics. And these differences between males and females with bleeding disorders continue to perpetuate disparities in care for women and girls with bleeding disorders. As such, the aim of this principle of care is that all patients with bleeding disorders and all individuals should receive equitable care. And it's important to recognise that access to care starts with recognition and diagnosis. Improved educational strategies are required in order to really influence people's beliefs regarding bleeding disorders affecting women and girls. And this should involve both healthcare professionals and the public to inform on the broad range of bleeding conditions, their impact on women, and how to refer and manage women and girls with bleeding disorders. Once patients are referred for assessment in the haemophilia treatment centres, clear management pathways and strategies should be available for women and girls with bleeding disorders. Our next steps will be to ensure access for both female-specific and general bleeding symptoms for all women and girls with bleeding disorders. And their care should focus on a multidisciplinary team input, offering appropriate treatments and counselling where needed. The second principle of care focuses on timely and accurate diagnosis of bleeding disorders in women and girls. It's been proven time and time again that women and girls with bleeding disorders frequently experience diagnostic delays. This is often due to a failure to identify female family members who could be affected in known kindreds of patients with bleeding disorders. However, for those who are yet to be diagnosed, there's often insufficient recognition of abnormal bleeding. And this is in part due to normalization of abnormal bleeding by both individuals, their families who may also experience disproportionate bleeding, but also by healthcare professionals who are influenced and shaped by their own personal experiences. The aim of this principle of care is to improve awareness of bleeding disorders and their impact on women and girls. We hope that this will reduce delays in both referral and assessment of women and girls with bleeding disorders, and that prompt testing can ensure an accurate and timely diagnosis. The next steps will be to aim, first of all, on reducing referral delays. The mainstay of this aspect is education, both of the public and healthcare providers, about what constitutes normal and abnormal bleeding patterns. There should be a specific focus on those specialities which are often a gateway to a diagnosis, such as pediatricians, general practitioners or primary care practitioners, gynecologists, ear, nose and throat specialists, and also education through national member organisations to improve public awareness of bleeding disorders. When there is a concern about a bleeding disorder, it is essential that every country and centre has clear referral pathways and criteria for referral, and that these will also capture women and girls with bleeding disorders with their symptoms. In terms of assessment, it is important that expert haematology input is involved in hemostasis testing and interpretation, as the diagnosis of bleeding disorders is often complex. We would recommend the use of standardized bleeding assessment tools, or BATs, in order to determine phenotype. And in the haemophilia treatment centres, there should be a systematic approach to testing, including genetics where appropriate, of female carriers. There should also be appropriate registration of female carriers and women and girls with bleeding disorders, including using new diagnostic categories such as mild haemophilia for those with reduced plasma factor 8 or factor 9 levels, or symptomatic carriers for those who may have normal levels but still experience significant bleeding. In families where there is a history of a bleeding disorder, affected female relatives should be sought out and referred for testing, if desired. The third principle of care focuses on the additional challenges that women and girls with bleeding disorders face throughout their lives. As we are all aware, women and girls with bleeding disorders experience both general bleeding symptoms that may be experienced by males, but also additional female-specific bleeding. And this can occur right from childhood through to the menopause. There is often an underestimation of gynecological bleeding by patients, individuals, their family who may have similar heavy menstrual bleeding or experience postpartum hemorrhage bleeding, but also by healthcare professionals in our networks. Delayed diagnosis, as we have touched upon, remains a significant problem for women and girls with bleeding disorder, and this can lead to impaired management, iron deficiency, anemia, and have direct impacts on quality of life, social participation, and anxiety. For women who experience postpartum hemorrhage, this interferes with the normal process of childbirth and can significantly adversely influence their future decisions regarding childbearing. So when we think about the different life stages that women go through, of course they experience all the general bleeding symptoms that men may experience, such as epistaxis, post-surgical bleeding, but they also have individual problems that are specific to women and girls with bleeding disorder. In childhood, they may not be offered testing routinely for clotting factor levels, particularly in carriers. As they approach menarche, they are at risk of having heavy menstrual bleeding and require education regarding the normal menstrual cycle. In young adulthood, monitoring heavy menstrual bleeding and providing individuals with triggers to contact haemophilia treatment centres if their bleeding is worsening is important so that patients are aware of when their symptoms may be more significant than they appreciate. Preconception, it's important that women and their partners are aware of the hereditary influences of their bleeding disorder and how that may affect any future offspring, and be offered pre-implantation genetic diagnosis or genetic counselling if appropriate. In pregnancy, we aim to minimise the risk of both antenatal and postnatal bleeding. And at delivery, it is important that we also consider the risk of secondary postpartum hemorrhage and that this is not forgotten about as women return home. Challenges associated with breastfeeding or heavy menstrual bleeding recurring after delivery should be attended to. And as women approach the menopause, dysfunctional bleeding may occur again, even on women who have a previous history of controlled menstruation. The aim of this principle of care is to highlight these additional challenges and to improve preventative and management options. Once again, our next steps will focus on education of both women, girls, and healthcare providers. It is important that psychological support is not overlooked because quality of life is often impacted, as is work or schools or sports participation for women who experience heavy menstrual bleeding. Sexual and reproductive functioning may be impaired due to the presence of the bleeding disorder, previous negative experiences regarding bleeding in the postpartum setting, or concerns about passing their bleeding disorder to their offspring. Improved medical management is essential for heavy menstrual bleeding in order to minimise the risk of early hysterectomy, which is still far more common among women with bleeding disorders than the general population. The first step for every woman should be an individualised treatment plan that addresses their specific needs and has a plan to support them and improve their bleeding symptoms. It's also essential that we empower our patients to have better control over their periods and influence their choices regarding the optimal therapies for them. Improving period monitoring using tools such as the My Sisterhood app or the PBAC score can help in communication and discussion with healthcare providers regarding heavy menstrual bleeding. In Principle of Care 4, we focus on comprehensive care of bleeding disorders using a family-centred approach. And our current problems really is that we tend to focus our education on women and girls who have bleeding disorders and their female relatives. And this really further risks stigmatising heavy menstrual bleeding and postpartum hemorrhage. And I think it's particularly important we include all family members, male and female, in this conversation to normalise these important topics. And even in those with a known history of bleeding disorders, affected females are often overlooked and may not be offered screening. So the aim of this principle of care really to foster a holistic family-centred approach within HCCs, which is what many of us are already currently doing, but to help provide support and education to the entire family. This will help encourage and facilitate screening of family members and hopefully normalise conversations about bleeding within families. Our next steps is that every patient contact in our centres should be considered an opportunity to identify other affected family members who may not have yet been offered testing. As we saw in Principle of Care 2, it is so important to have a systematic approach to the screening of potential carriers so that women may be alerted to their possible carriership at an early age. And we should provide a family-centred approach to education, particularly with girls with bleeding disorders. Thank you.
Good afternoon or good morning wherever you are. So our next principle of care is to include an dedicated obstetrician and gynecologist in the multidisciplinary team providing care for women with bleeding disorders. Of course, any comprehensive care for women is not complete without inclusion of obstetric and gynecological services. Well, despite the fact that heavy menstrual bleeding and gynecological problems are the main issues for women and girls with bleeding disorders, currently there's lack of consistent and good collaboration between the hemophilia treatment centers and obstetric and gynecology for most of services in Europe. This is a survey that was done by European Haemophilia Consortium, surveying or asking a treatment center how they provide care for women, and it becomes clear that more than half of the centers did not have a specific joint clinic or multidisciplinary clinic for women or clear pathways for managing gynecological problem. As a matter of fact, one in 4 centers did not have a dedicated gynecologist or named gynecologist to liaise with for advice in relation to gynecological conditions. All the centers realized the importance of such a setup, but they reported barriers, mainly institutional and financial, to set up this service. When it comes to pregnancy, we know that women with bleeding disorder have high risk of bleeding complication for the mother and the baby. So it is important that they are looked after by a multidisciplinary team, including midwifery, obstetric team, anesthetists, neonatologists, in collaboration with the Haemophilia Treatment Center. But having a dedicated or a named obstetrician that is experienced in managing bleeding disorders and also known by the staff in the maternity unit as well as the hemophilia center is very important for provision of continuity of care from where the mother plans the pregnancy throughout the pregnancy, delivery, and postpartum period. So the aim of this principle of care to improve management of obstetrical and gynecological bleeding for women, because we know their reproductive issues is more than just having heavy menstruation. And as I have illustrated in the slide, they have a variety of gynecological bleedings and conditions, commonly ovulation bleeding, endometriosis, and that highlights the need for skills and expertise of obstetrician gynecologists to really deal with this diverse and complex issues. In pregnancy, of course, the ultimate aim is to have a safe pregnancy and delivery for the mother and baby. Again, this can be achieved by advanced risk assessment and planning care by the multidisciplinary team, and also very finely nuanced birth plan that covers all eventualities. So with this principle of care, we will empower women to have access to safe level of care, and also enable healthcare professionals and hemophilia treatment centers to set up such care that includes a joint clinic or a collaborative service for women. And we know the value of these kind of clinics and services well proven. This is a survey we did at the Royal Free Hospital of women who are attending our joint clinic, and as you some of you know that we've been running this clinic for almost 20 years, and all women reported high satisfaction with the service. They felt that they were given an individualized care that was centered on them, with good communication and less hospital visits. So next principle of care is education of women and girls and their families of menstrual cycle, what is normal and when should they be concerned and ask for help. Well, again, we know that having menstrual bleeding is the commonest bleeding symptom for women and girls in these families, and majority of them suffer from having menstruation at some stage, if not throughout their reproductive lives. But actually, heavy menstruation is really underestimated and seen as normal in these families because everyone has heavy bleeding and they just cope with it. And this leads into delay asking for help and getting the right treatment that is very important to prevent long-term consequences and the impaired quality of life. So as part of the comprehensive care that Haemophilia Treatment Center should provide for women and girls should be a continuous education of the relevant issues that's pertinent to their age, stage of reproduction, their cultural and social backgrounds. And this is specifically important for young girls just before they start menarche and their families, of course. And in our joint clinic, we often use illustrations such as these to clearly show them what happened at menarche, what happened during a menstrual cycle to their hormones, to their organs, ovaries and uterus, what kind of bleeding or pain they should be expecting, and also some written information, simple, to show them what is normal and when should they call us for advice and help. And in addition to this one-to-one education that should be provided by Haemophilia Treatment Center, medical societies and patient organizations should also play an active part in providing reproductive education through conferences for women, maybe training camps, of course information in different languages that distributed to these patients through the organization, as well as guidance for healthcare professionals looking after these women, not only to help early diagnosis, but also to anticipate at a time of change, for example, menarche and menopause, and that's how we can prevent bleeding complications. And this will lead me to this the seventh principle of care, which is early recognition and optimal management of heavy menstrual bleeding. And I'm sure you agree that this principle of care cannot be achieved without the level of the education and the knowledge that we have just discussed in the previous principle of care. Well, the negative impact of heavy menstrual bleeding for women and girls is well recognized, and we all know about it. And this is a survey that we conducted via the European Haemophilia Consortium a couple of years ago. And more than 700 women from 32 European countries responded, and they reported that heavy menstrual bleeding was the bleeding symptom that has the worst impact on their life, all aspects of life, physical, social, active life, romantic life. And as a matter of fact, one in 4 women reported that it heavily or severely influenced their decision making when it comes to starting a family or planning to have more children. So it is obvious that by early diagnosis and providing treatment, appropriate treatment for heavy menstrual bleeding, that we can improve the quality of life of these women. And this is really achievable through regular review of women, like we do in the Haemophilia Center for men with hemophilia. We should have probably annual review to ask them and inquire about menstruation, encourage them to use menstrual charts such as this to help them easily identify when they have heavy menstruation. We should be doing regular assessment for iron deficiency and anemia. And we also must remember that when they have heavy menstrual bleeding, they are like any other women. They could have gynecological problems such as polyp, fibroids, and others illustrated here. Therefore, the investigation should also include a thorough gynecological assessment. And to achieve this principle of care, Haemophilia Treatment Centers should really adopt a clear pathway for diagnosis and management of heavy menstrual bleeding. And the aim of the management should be a provision of a holistic approach to lead to improvement in quality of life, not just focusing on reducing heavy menstruation. And this is can be obtained by taking in consideration whether the woman has other gynecological condition or symptoms, her fertility wishes, her acceptance to the treatment options available, the side effects, her values, expectation, as well as religious and the cultural background that could influence the treatment option that she would like to take. And as I have shown you in this algorithm of treatment that is commonly used for women with bleeding disorders, there are many options to help heavy menstrual bleeding: hormonal, non-hormonal, surgical. But the role of the multidisciplinary team and the healthcare professionals should be to help women and girls to make an informed choice for the option that suits them properly at that time. And that's how we can really improve quality of life of this woman. And thank you very much. And here I will hand over to Dr. Karin van Galen to discuss the last 3 principles of care. Thank you very much.
Thank you very much, Rezan. Here are my disclosures. The 8th principle of care is to provide preconception counseling and access to prenatal diagnosis for women and girls with bleeding disorders. Women and girls with bleeding disorders may face difficult choices when planning a family. Lack of awareness and knowledge regarding their bleeding disorder and inheritance pattern is associated with increased risks for both the mother and her offspring. As soon as women and girls with bleeding disorders consider to start a family, counseling should be available that covers the prospective mother's own bleeding risk, as well as the inheritance pattern and risks to the offspring. When appropriate, prenatal diagnosis should be discussed and available at haemophilia treatment centers. When the available options for mitigating bleeding risks of both mother and child are discussed with the parents-to-be, they should feel able to make choices freely without fear of judgment. It is important for them to understand the current treatment perspectives in order to make informed decisions. Prenatal diagnosis can be performed early in pregnancy and should be available promptly if the mother wishes to consider termination of pregnancy in case of an affected child. In this case, parents-to-be should be aware that invasive prenatal diagnostic procedures carry a slight additional risk of miscarriage that lies between 0.5 and 1% above baseline. Late in pregnancy, at around 33 weeks of gestational age, prenatal diagnosis with amniocentesis can be offered to guide obstetric management if appropriate. You may not all be aware of this strategy to prevent transmission of severe inherited bleeding disorders to offspring using prenatal genetic diagnosis. This technique involves in vitro fertilization with selection of genetically tested embryos that are negative for the familial causative variant. Sufficient time should be reserved to discuss the burden, risks, and benefits of PGD, including any maternal bleeding risks associated with the related invasive procedures. The availability of PGD may be limited for financial, technological, cultural, or ethical reasons, so women and girls with bleeding disorders and partners should be informed about limitations and any criteria used to enable access to this option. Checklists and prenatal diagnosis decision tools or written information can be helpful in providing complete and adequate preconception counseling for women and girls with bleeding disorders. The 9th statement regards provision of a patient-centered comprehensive management plan for pregnancy and the postpartum period. Women and girls with bleeding disorders are at a higher risk for both primary and secondary postpartum hemorrhage, and their newborns who may inherit the disease have an increased risk of bleeding during birth. Insufficient preparation and anticipation on these potential bleeding complications may cause negative birth experiences, which negatively impacts mental health next to obvious undesired physical and medical consequences. A timely, multidisciplinary drafted birth plan that's communicated very well among healthcare providers and the women and partner enhances safe birth and delivery. To further enhance a sense of safety and autonomy during childbirth, both parents-to-be should be involved in preparing the birth plan. A multidisciplinary provisional birth plan should be ready from 24 weeks gestational age onwards to cover all eventualities, including preterm delivery. Clear communication, documentation, provision of the birth plan to the mother, and all relevant healthcare providers expected to be involved in her care is essential. Iron levels should be checked and iron deficiency should be treated during pregnancy to mitigate risks of adverse maternal and neonatal outcomes. Also, after pregnancy, iron deficiency should be treated to fasten recovery. Prolonged use of tranexamic acid after delivery reduces the risks for postpartum hemorrhage, secondary postpartum hemorrhage, and it can be used during breastfeeding without any known adverse effects. Clear and specific advices regarding hemostatic management during delivery and postpartum, suitability for neuraxial anesthesia, fetal restriction requirements, if any, and postpartum neonatal management should all be included in the birth plan. There is a need for more international consensus on optimal management strategies for safe delivery in women and girls with bleeding disorders. Which brings us to the last principle of care. Last but not least, women and girls with bleeding disorders should be involved in research, registries, and innovation. Until now, clinical research on impact and management of bleeding disorders has mainly focused on males with hemophilia, with limited data on women and girls with bleeding disorders. The lack of standardized inclusion of women in national and international registries and failure to capture female-specific outcome measures play a major role. It is also insufficiently acknowledged that gender-based differences impact pharmacokinetics, which hampers therapeutic optimization. More involvement of women and girls with bleeding disorders in clinical research will afford improved knowledge on effective diagnosis and treatment. Consistent and harmonized inclusion of women and girls with bleeding disorders in national and international bleeding disorder registries is a prerequisite to enable better understanding of the impact of bleeding disorders in women and girls, and to understand which treatments effectively reduce female-specific bleeding plus its consequences. To improve knowledge, next to consistent and harmonized inclusion in registries and capturing female-specific outcome measures, increased attention should be paid to gender-specific pharmacovigilance and drug development. And to ensure best treatment and outcome assessment in this patient group, they should themselves be involved in clinical research, including the study conception, co-design, and scientific boards. In conclusion, 10 principles of care for women and bleeding disorders have been defined based on an iterative process within the European bleeding disorder community. These principles of care can serve as a benchmark to improve awareness of unique women and girls with bleeding disorders challenges and to support their diagnosis and comprehensive multidisciplinary management. They offer a framework for hemophilia treatment centers to provide equitable, high-quality care for all women with bleeding disorders, both in their own services and other healthcare settings. Principles of care implementation and adherence is expected to positively impact their quality of life, improve social participation and engagement in clinical research and clinical care. Thank you very much for listening. Now we will proceed to the Q&A and panel discussion session. Please do not hesitate to ask questions or to give your comments. We have reserved plenty time for this discussion of these first European principles of care for women and girls with bleeding disorders, and we also hope to have vivid interaction with you. The following working group members have drafted the principles of care with us, our 4 speakers of today, and we're very thankful and honored that most of them are also present as panel members. This includes Deborah Pollard, haemophilia nurse at the Royal Free in London, Kate Kerr, research director of HemeNet in the UK, Keith Gomez, hematologist at the Royal Free in London, Ellen van Loon, psychologist in Leuven, Evelien Mauser-Bunschoten, very experienced haemophilia treater from the Netherlands, Catherine Bagot, hematologist at the Royal Infirmary in the UK, Katelijn Fischer, a pediatrician working at the Van Creveldkliniek in the Netherlands, Petra Elvinge, a haemophilia nurse, and Roseline Doiron. Last but not least, it was actually her idea to draft these principles, and she works as a hematologist in Paris. I hope we'll have a nice discussion.
Well, good afternoon, everyone. I hope everyone enjoyed the presentation and got a better feeling of what these principles are all about. And now have a lot of questions to ask to unfold some of these principles, maybe unfold some of the thinking behind it that we haven't touched upon yet. So feel free to raise question in the question and answer box, which is at the bottom of your screen. And I will try to moderate it as good as possible. On the videos, you can see the 3 presenters, Dr. Michelle Lavin, Dr. Rezan Kadir, and Dr. Karin van Galen, who have, as you know, already presented the principles. And I will try to direct some questions to you and maybe also some of the other working group members who are also present today. But maybe, Dr. Karin, if I can start with you, just overall, what do you see as the greatest challenge to draft these principles?
Well, the greatest challenge to draft these principles. There was quite a long process because you need to involve all relevant stakeholders, and everybody has a limited time, of course. So that's a big challenge, but I think we quite fast. We didn't need that much time to agree on the principles themselves, because it's actually a bit sad that it's needed or that it hasn't been done 20 years ago, actually.
Yeah, I can only agree from the patient side. It's been long awaited that we've been able to have these principles. So Michelle, it looks like you really want to say something as well.
I'm just very excited to see how many people have registered and have been involved, because I think if you're a woman with a bleeding disorder, or if you have an interest in treating women and girls with bleeding disorders, it can sometimes feel a little bit of a lonely place, and we can be eclipsed, I suppose, by the other major bleeding conditions. But I think there's a lot of momentum behind women and girls with bleeding disorders at the moment, and I've been really privileged to work with such great colleagues in both EAHAD and EHC to try and develop these. And I think that this should be hopefully the first iteration of many new guidelines on women and girls with bleeding disorders in the future. But by defining these principles of care, we hope to really start the conversation and to introduce care for women and girls in their haemophilia treatment centres in a way that hasn't been systematically approached before. So I'm just excited to be here and to be part of the conversation today.
Yes, well, there's some questions popping in from the participants, and I might want to start to ask you, we talk a lot about education, and there's actually a question about, could you see potentially these principles be a part of the curriculum for medical students, or what kind of knowledge does the medical student need in order to be better at identifying women with bleeding disorders when they go out into practices afterwards? Don't know, Michelle, you're knocking.
Yeah, so I think when I think back to learning about bleeding disorders as a medical student, I mean, a lot of the information is based about the genetics of haemophilia. And I think that's already introducing a bias at very early stages in people's medical career, that men have haemophilia and women are carriers and are not affected. So that's probably the first message that's getting out there about haemophilia as the archetypal X-linked disorder. So I think that needs adjustment. But probably, if you're going to teach a couple of things to really encourage awareness of bleeding disorders, it's first of all, what are normal bleeding symptoms versus abnormal? So when does a nosebleed become problematic? When is a period abnormal? But also taking a menstrual history. So if we ask to take a respiratory history, if we're in medical school, you learn like cough, shortness of breath, all the symptoms. And if you ask somebody, how do you take a menstrual history? They say, are your periods heavy? No, yes, that's it. And that, of course, is going to be shaped by the woman's own perception. And many people will say their periods are not heavy, but when you go into it, it's 7 or 8 days long, clots flooding, heavy for 4 or 5 days. So I think that we need to encourage awareness of bleeding by actually teaching them the questions to ask, and that taking a menstrual and gynecological history should be a standard part of a female assessment. I'm sure Rezan probably feels strongly about that too.
Yeah, absolutely, Michelle. I completely agree with you. The other point I want to add, medical students learn by visibility. So with this principle of cares, we make women and girls visible in the hemophilia center. And this is how they learn when they come to the clinical session. If the hemophilia center is, they see these patients coming for follow-up, they see there are information for them, there's a family approach, and that's how this will be embedded in their teaching and will take it further for their medical career.
Yes, and maybe make it a bit less complex too, because just hand them easy tools. When do they have to think about a bleeding disorder? What do they have to order in the laboratory? And less focus on difficult coagulation cascades, because that's what most students remember, that they think about coagulation as something very difficult, and then yeah, that's it. So we need to have more practical advices during their education. I think that's also important.
And maybe if I can forward the questions to Deborah Pollard, because I know you're also very active in terms of education, and also in your position as Director of Education at the HemNet. And now we're talking about education of med students, potentially hematologists, healthcare providers in a broader sense. What are your perspectives on it?
So thank you, Naja, and congratulations to everybody involved, because this is really a great step forward. I think very much, as I look around the faces I can see and the names I can see in the question box, that we of course are really talking to people who know and understand what we're talking about. And one of my biggest concerns is how we get the information to the non-specialists, picking up on Michelle's point that really, as the medical student goes through, there's no flagging for them as about a woman with a bleeding disorder or a girl with a bleeding disorder that will carry into their career. If they are a cardiologist, or they are an orthopedic surgeon, or in emergency medicine, they're really not looking out for women and girls with bleeding disorders. And so I would say that for me, there needs to be a really proactive movement from both the healthcare professionals and the NMOs to help young women, girls with bleeding disorders, to advocate for themselves when they are dealing with non-specialists, and for us as the specialists to really advocate when we are forced to refer girls and women out to other services, that we are very clearly advocating on their behalf. And I think we can use these principles to guide us, but I think it's really important to bear in mind that a lot of the time our community are coming against very clever and specialist treaters who have no idea about our disease area. And it's very important because they meet some prejudice.
Yes, absolutely agree. The women meet a lot of ignorance, potentially, or a lot of barriers to actually communicate with doctors, nurses, healthcare providers in broader sense, in terms of just explaining what their symptoms are, but they also sometimes are very much have difficulties knowing what their own symptoms are. Actually, they don't necessarily know that much about their own disorder because they haven't been diagnosed yet. And that's even the first issue for a lot of these patients. And then after you are diagnosed, you then meet a lot of patients, doctors and nurses that might not recognize it, that you have these issues. So it's going forward and back and forward and back and forward and back for the patients along the way. And thank you, Deborah.
Naja, just to interject again with another comment for medical school, and a really important message to get out, and something we all talk about, I know Deborah feels strong about this too, is that a normal coag test doesn't mean you don't have a bleeding disorder. And often the preoperative assessment that's undertaken on patients is they do a coag test. You know, that doesn't tell you anything about whether that person's going to bleed or not. The majority of our patients have a normal coag test, which is just your PT and your APTT. So it's really embedding that idea that the bleeding history is what we should be taking on patients, and not relying on tests that are insensitive to bleeding disorders, but people are over relying on to reassure people falsely. And I worry that there's a lot of women, girls, men, boys who are not being referred for a proper workup because somebody does a coag test and tells them, well, that's okay, you know, and believes, because maybe they've never learned any differently, that that's actually outrooting a bleeding disorder.
Yes, absolutely. And I know some of the principles are also very much into the referral, because you need to go to the specialist to get the right test, the right analysis of the test, and as well as of the symptoms. But maybe also one of the other healthcare providers group that are seeing a lot of women out there who might not know much about bleeding disorders are the gynecologists and obstetricians. And we actually have one question about if the panel has any suggestion on ways we can incentivize obstetrician gynecologist colleagues to have a special interest and be named or dedicated in the role as the specialist when it comes to women bleeding disorder. Also because some of them might see it as an extra workload, might see it as relevant. But do you have any, maybe we should start with you, Rezan. You come from the gynecologist area. Why did you find it so interesting to work with women bleeding disorder, and how do you convince your colleague that this is just the most interesting thing to work on?
Yeah, thank you, Naja. It's an interesting question. And I think in this day and age, obstetric and gynecology is also, there's a lot of subspecialization. So I would not be, I think obstetricians and gynecologists are interested to have their own area and to lead on it. So I don't think they need to be convinced. But I think it's all about the starting dialogue. I think the Haemophilia Treatment Center should start the dialogue with the maternity services to build up, and I am sure they won't be short of people who will come forward. That is number one. Number two is, you exactly said right, how it affect there, because obstetrics and gynecology is a very busy specialty, and it is a hard-working specialty. You cannot build it on basically to do it extra as an extra time, and that's how we built it. Me and Deborah, we just did the clinics, so the women like out of our working time, and then eventually become part of an established service in our center. I think to start with, it should be well financed, well supported by the Haemophilia Treatment Center. They have their own clinic, their own services, because it's not easy to see obstetric and gynecology patient in Haemophilia Center. Deborah remembers first time we did clinic, one of our hematologists was terrified to see a speculum in the clinic room. So we need to set it up properly, and I think finance properly, and actually these principles of care and the education that comes with it, and also it becomes like some part of principle that the services should be assessed when they have their inspection, and that way it will become part of every service.
Yes, and I'd like to add that, you know, as a hematologist, we also have to offer them a lot of expertise because they really deal with complex coagulation situations and many coagulation disorders during pregnancy. which increases the risks, or with heavy menstrual bleeding that they can't really explain. So they need us too. So it's very a good thing to have a close collaboration, and then it evolves into a joint clinic. That's a natural process, actually.
Yeah, absolutely, Karen. I think, I learned so much through my working with the hematology nurses and specialists and the physiotherapists there. So it's a really shared learning for us, and also providing a comprehensive care. Otherwise, it's not going to be a comprehensive and a joint service.
Maybe we can take that question a little bit further to the idea of joint clinics. Maybe Michelle Lavin, if you want to explain how you see the joint clinics, and maybe also Rezan and Deborah has working a lot on the joint clinics, but what are your perspectives on the joint clinics and working on that and get it established? Is it something driven just by one person, or what? Well, how do you see that?
I think around? We're in a different situation in Dublin, that we have a joint obstetric clinic. So we have a joint hematology in obstetrics clinic for our women with bleeding disorders or thrombotic disorders, but we don't have a joint gynecology clinic. So we're still referring people over to be seen, and that has a lot of inherent delays with it. So one of my particular areas of interest is obviously, to really look and establish this, and it's something I'm currently working on. But actually I found that people are very receptive in the obstetrics gynecology side, because I think that in obstetrics and gynecology, there seems to be a very strong emphasis on the obstetrics side, the pregnancy side, but maybe not so much on the gynecology. So when you go find somebody who's interested in gynecology, and you see you're interested too, you actually have natural allies in the gynecology clinic. And there's usually a specialist in the hospital that's interested in heavy menstrual bleeding. And I think it's about what we offer each other, that we're not just asking for a service for our patients with bleeding disorders, but in fact that they have a lot of women who are attending with heavy menstrual bleeding who could have an underlying bleeding disorder. So whenever you get to that stage, if you're attending a specialist heavy menstrual bleeding clinic, and if you're a repeat offender, if you're coming back and you still aren't really getting to the bottom of why your periods are still heavy or poorly controlled, the chances are fairly high that you'll probably have a bleeding disorder. So I think that we can offer solutions to them, not just problems. We can say, well, look, we're actually really interested in this particularly difficult cohort of women that you have that can be very difficult to manage. We would like to do their testing if they have recurrent iron deficiency, if they've got heavy menstrual bleeding, could they have a bleeding disorder? And in that way, we actually can gain early diagnosis for those women if they have an underlying bleeding condition. And we're also offering a service to our gynecology colleagues. And in turn then, that we would ask them to help us with our patients who have an established bleeding disorder but have poorly controlled heavy menstrual bleeding, or of course when they're pregnant, to have that obstetric service. So I think it shouldn't be looking about, it's very hard to go just asking for things from people because everyone is busy and resources are limited, but we should look at what value we can both bring to each other's services rather than remaining siloed and saying we just look after the bleeding disorder side, they just look after the gynecology. How can we actually bring that together? And that's obviously hugely beneficial to the patient if they can have a joint clinic. And as Rezan has mentioned on a number of occasions, we don't need this to be an in-person clinic all the time. I mean, obviously, if they need to have investigations done, that may be more appropriate at either the Haemophilia Centre or the Gynecology Centre. But there's great teleconferencing availability now because of the COVID lockdown. And we should look at how we can use that to really adapt our services in an efficient way.
Absolutely. I can also see a lot of nodding around. I think everybody very much agree on that. Dr. Dr. Rosalind Doiron from France just raised a hand in relation to the gynecologists and the joint clinics. Thank you for joining.
Thank you very much, Naya. And first of all, I would like to say that it is such a delight to see this achievement and that step that we are today. So really, that's a lot of work for all the group, and to be part of this fantastic expertise. I'll also continue to learn a lot from all of you. And so really, I wanted to say thank you for that, because that's a fantastic opportunity to share. Just 2 points I would like to mention. The first is about the barriers to diagnosis of what bleeding symptoms are. I think that similarly, the barriers that we can have, for example, for pain assessment, I think that we have potentially the same barriers to diagnose what bleeding symptoms are. And certainly there will be a lot of new area here to explore in order to improve the very early times that guide to the diagnosis period. And certainly there will be a lot of research to do there, I'm sure. Second, about the joint clinics, frequently when you have a referral, a gynecologist to refer a patient already diagnosed with a bleeding disorder, it is sometimes at any point, and I experience that many times with some patients, there is a kind of ping pong game, you know, between the gynecologist and the hematologist. And we arrive sometimes to one point where you may have different, I would not say opinions or strategies, but sometimes it is not efficient just for the patient. And so having this discussion together with the gynecologist, the patient, and the hematologist there in the same time at the same location, and to discuss with the three different opinions, and that will be a real shared decision about the strategy. And I think this is extremely powerful and efficient. And so final point, how to involve gynecologists. I think that's something that is frequently shared by other clinicians when we discuss joint clinics. They frequently say that their gynecologists are not interested in bleeding disorders in women. And I think we as hematologists may have a part to play, which is to say that developing common studies or developing common activities or projects, organize a conference in your hospital about this issue, and invite the gynecologist one time, a second time, a third time, and then they can't get out of it. And so they come interested in it. And so this is how it works. Involve them in your activities and they will stay with you. They will not go away anymore. So I think that's just one of the tips we try to have here. Thank you.
Thank you very much, Dr. Duong. We have a little bit some questions coming into the space of economics in terms of studying more cost effectiveness on treating women with bleeding disorder, the cost of hemophilia, the cost of a heavy menstruational bleed. Maybe I know this working group has been focusing mainly on these principles, but maybe I know a few of you is also very much involved in a lot of other committees and a lot of other work, and most of you also work in the EAHAD, a women working group. Are there any sort of ideas or incentives to work more on the cost effectiveness or the economic side of women with bleeding disorders, for example, in a study or any research on it from the EAHAD side? Don't know if Dr. Karin, you want to see, is that something that could be interesting to, again, make more emphasis on these issues?
Definitely. For now, I think we're at the stage that we have to start a project to define which parameters we should capture, which female specific parameters we should capture in clinical research to have more data. And but in the future, you can imagine that heavy menstrual bleeding, if it leads to fail days at school and days at work, that comes at large cost of the society, and that must be possible to have models to know how much money that costs. But if you can manage to get them to a higher education level, or have less days lost from school, days lost from work, those kinds of outcome parameters could be very important to calculate economic benefits of treating heavy menstrual bleeding.
And
Rezan, yeah.
Yeah, I think if you want to convince your hospital, or even if we are in UK, we have lucky to have NHS, so it's about the hospital building it, or in places where there are insurance, to convince insurance. It is important to show them the cost effectiveness at the end of the day. And if you have any data to support that, then this service building and setting up, it will be much, much easier. So I think it's a very good idea. I know it's hard, but I think it's an excellent idea to start thinking about that, setting some research, and maybe once these principles of care is adapted, we could do some comparison of before and after and present something that could support that what we're doing is also cost effective.
Dr. Michelle Lavin?
Yeah, so the one study that I'm aware of comes from the US National Inpatient Sample, and I think it included data up to 1991 and then was published a couple of years later. I can put the link up later on if anyone's interested in looking at it. But they looked at just a very crude way, not including women with bleeding disorders, but if you were coded for heavy menstrual bleeding, and then they normalized for, you know, ethnicity and age and your occupation, and they found that there was an economic disparity between women who were coded for heavy menstrual bleeding and those who didn't have that code, and that amounted to about $1,900 a year, and that was in 1991. So we're talking about 30 years ago. So it was a significant impact in terms of their earning potential, just by when they tried to normalize for other factors the presence of heavy menstrual bleeding. Like, obviously that's a very crude assessment of it, but I am aware of any other economic evaluations since. But I think that really speaks to the problem we all have, is that how neglected this topic is. But if you're a woman who's bleeding for 7 days every menstrual cycle, you're going to be bleeding for 3 months a year and probably regularly iron deficient. And we know the impact that iron deficiency has in terms of concentration, performance, quality of life. But I think it really just shows the inherent kind of the lack of interest in this area, that people don't focus on women's bleeding and don't prioritize it. I think it's hard enough being, you know, a woman working, you know, having a family, trying to juggle everything. I can only imagine if you put a bleeding disorder and iron deficiency on top of that, how difficult that becomes. And I think what we really need is better female-specific standardized questionnaires that can capture that information, because when you think of the questionnaires about bleeding disorders, they're largely designed for men with haemophilia, and we don't have specific tools that can answer these, that can collect this information in a standardized fashion from women. So maybe that can be one of our next projects.
That would be excellent. Yes, I think so. I know there has definitely been some work going on currently, actually over the last 2 years, to design some better fitted surveys and questionnaires for women with bleeding disorders, because yeah, it doesn't capture all the things we see when we suddenly talk to them directly or we ask for case studies. So it would be hugely beneficial to get that, and defining patient outcomes more relevant to the patients in questions. Also, when we talk about principles of care 10, which is about the registries, so what data is it actually that we are capturing, when it becomes relevant for research and when it becomes relevant for the patient's everyday life. We have a very direct questions when it comes to genetic testing and when to do that. I know it's been an ongoing question for as long as I remember, when to test and when not to test. And it's an interesting conversation because there's also a lot of ethics around it. There's also new methods been developed over the years. And I think it's interesting that nowadays you test babies within the first week of if they have cystic fibrosis, for example. But the discussion about testing girls who come from a hemophilia family, they are reluctant to test them even though they're 15 or 16 years old, because we might not want that information. So there is obviously some differences when it comes to this aspect of when to test, and why is that? I don't know exactly, but maybe Keith Gomez, you are also here and working a lot with genetic testing. What do you see about when is the right age to start the conversation about testing girls who comes from a hemophilia family?
Yeah, I mean, I think Naja, you've already highlighted many of the issues here, and I think you can look at it in two different ways. To some extent, it's about what is the question that's being asked, because let's say we have if there's a young girl in a haemophilia family and she needs some surgery, and the question, and then you might think, well, we need to know whether that girl's a carrier or not. But in fact, perhaps actually the question being asked there is not, is she a carrier? It's, is there going to be an increased bleeding risk during the surgery, which might be better assisted by knowing the factor level, for example. But if you are specifically want to know whether someone's a carrier or not, which is perhaps more likely to be of relevance later on in life, then as Michelle already said, we know that genetics is really the best way of determining that, certainly in a haemophilia case. But you're quite right that I think doing genetic testing, particularly now when we do it mostly by next generation methods, and certainly outside of haemophilia, if we're thinking about other conditions, then there's an awful lot that goes with that. And I think that needs to be explained and understood. And that may be one of the reasons why the possibility of finding out different variants, essentially incidental findings, may be one barrier in some situations for parents wanting to test their children. So I think it depends upon the clinical situation, and rather than it necessarily being a specific age thing. And of course, once you're in that decision-making process, of course, there'll be a question about the ability of the child or the young adult to understand the information that's being presented to them. And I don't think there's an easy answer. And certainly, while we've got lots of guidelines on how to consent for genetic testing in adults, I think there's still plenty of work to be done. And certainly in the UK, there's some ongoing work about transferring that to children. And that has to take into account the clinical situation. So you mentioned cystic fibrosis, where there's clearly some effects on management early on in life. And I think if I was going to try and give just one broad answer to this and try and summarize, I think I would say that the time to test really is when it's I look at it as when it's going to be clinically relevant, as opposed to just for the sake of it. That is, and there are exceptions to that, and I'm not saying that's a blanket, but roughly speaking, that's how I would look at it.
And if I may add, Keith, it's in relation to girls, it's before menarche. Is there the time, if there's not been explored, to see the bleeding risk when the period starts?
Yeah, absolutely. But again, there, just coming back to that, if the question is, what is this girl's bleeding risk when she comes to menarche, then the factor 8 level or the factor 9 level, for example, will help you enormously there. And the genetic testing is, I agree with you that's clearly an important part to help us make the diagnosis of, is this person a carrier or not? But I do think they are subtly different questions there.
Thank you. I know Kate Kerr wanted to also give her point of view on this question.
Yes, thank you, Naja. I think Keith and I could probably argue about this for 25 hours, but actually I'm not going to argue with him for a change. I'm just going to say that I think it's really important as we move forward with much better haemophilia care for men, and perhaps we see them less in hospital and lose them slightly, that we somehow know about the daughters that they're all having, and those girls get either a factor level or they somehow get registered so that they can be followed up at some point in the future at an age appropriate time, so that they're not just suddenly having a baby with haemophilia, having forgotten that their dad's got haemophilia too, because I think that's going to be potentially traumatic for everybody involved in 20 years' time.
Yes, I think no one is ever really, it doesn't seem like no one is ever really going to agree completely on a specific age on this matter. I think the discussion for the last 20 years, 30 years, how long it has been, shows that it's very difficult to find a common ground exactly on it. But I think what these principles will help doing, and just what this webinar is doing, is to highlight that we sometimes need to pay more attention to the family in general. And to really say, okay, we have these girls, we have these women in the family, we should pay attention to it a lot more than we have done before. And that might not be the genetic testing part, but it might also be assessment of their bleeding risk. And that bleeding risk could be well before the menstruation. A lot of things can happen before you are 11 years old or 12 years old. A lot of things can happen in your life, and that might be needed that we know your bleeding risk. But as long as we pay more attention to it, we hopefully will have these women and girls on the radar a lot more than before. So thank you for that. I think I would like to move into a little bit and saying, well, these principles of care are coming out. We already started a lot of discussion about it, but how do you, if I can start maybe with Michelle Lavin, how do you see this principle of care as a tool to raise awareness, just both within the community, saying the healthcare professionals, but maybe also the patients' organizations, and maybe also broader? How can this work? How is this feasible?
Well, I think it's hugely important because, first of all, you know, we have to, the fact that we haven't had principles of care for women and girls with bleeding disorders before this is kind of shocking. So it's great to have those outlined, so we at least have a guideline for what we expect, or what women should expect and what girls should expect for themselves when they have a bleeding disorder. So I think, well, first of all, how does it bring awareness? Well, I think the fact that there's been so much conversation about it on social media, that we've had so many people register for the event, that, you know, that so many people who even can't be here today are going to watch it online thereafter, that encourages conversation about the issues that women and girls face. And it's not just about, you know, heavy periods and about postpartum bleeding. It's about the access that women have to care in their centres, and the expectation that that should be just as equitable for any person with a bleeding disorder. So I think that that's hugely positive, that we can actually start that conversation. And I think for, you know, people that are attending different parts of different national member organisations, hopefully they can feel that perhaps their voice is being heard a little bit more today, and that they actually, you know, have an important place in the bleeding disorder community, and that their specific issues need to be, you know, reached and raised and dealt with. So that's what I hope it brings for people who already have a bleeding disorder. In terms of for those people out there who are not yet diagnosed, or for our colleagues in different healthcare professions, I think if we can speak to, you know, our other like areas such as gynecology or the accident and emergency department, and show that actually, you know, there is a role for women in bleeding disorders, there is needs that they have that are specific to them, and that there are these guidelines developed that we should try and adhere to. That makes it much easier to try and forge those links and build those communities locally. Whenever you say, well, actually, you know, there is European standards, how do we meet them? Help me work with you in order to try and improve care. So I hope that these principles of care, although they're quite broad, will translate to local changes that can improve care for women and girls in that area, and really focus a spotlight on this. Like, it's a much neglected area of care at the moment.
Oh, here you go. Thank you very much. Maybe Deborah, would you like to elaborate a little bit more so on your perspective on it?
So I was just thinking slightly sideways there, that if you're wanting to attract other clinicians to join with you, certainly I know from a very long time ago that a very interested registrar who wanted to do some research came along, and then our clinic was born in Rezan. And actually research is very often an attractive way to work with colleagues, you know, to combine expertise and to generate that interest. And I just think that, you know, I think it's so important in driving forward. Yes, we've achieved loads so far, and it's great to have this forum, but there's so much more we need to know and understand. And that comes from the collaborative research of all the healthcare professionals, and also working with the NMOs, because actually, you know, where would we be without that fantastic survey from the EHC as well? So I think it's really important not to put research to the side. It has to be part of this program right from the get-go. And I think that's really the way to bring in people who didn't know they were interested, you know, to generate that interest.
And Deborah, I think that comes back to the 10th principle as well, about involvement of women, not only in research, but in registries. Because if somebody's trying to conduct research and you can't even say how many women have a particular condition in your country, there's an inherent problem already there. So, you know, registries should be for every patient with a bleeding disorder, because you can't discuss the scale of the problem, or in fact find out what problems are important to the people who have that condition, without knowing, first of all, how many people are registered, how can you reach out to them, and how can we improve care. But I love to hear somebody else advocating research. Usually I have to be the one pushing it.
I think on the topic of registries, Naja, we should say that it's it's a very high priority of the EHC Think Tank Council to try and once and for all pin down the descriptors in registries and perhaps make it more uniform. And that would be hugely important for carriers of haemophilia. And I think also for heterozygotes for the other rare bleeding disorders as well. I think they get also pushed aside. I'm thinking of, you know, ladies who are mothers of severe factor 10 children, for example. And we know in our practice, we've seen those women who do bleed with a factor 10 level, you know, they have significantly heavy menstrual bleeding with a factor 10 level of, I don't know, in the 30s perhaps, but without being too specific. But yes, I think registries are key.
Can I say?
Yes, please go ahead.
Naja, it's really amazing what we achieved, like Deborah said, because when we started the research in this area, there was like hardly any publication. Not only that, there was none of the medical or patient organization had a women committee, and now we have a women committee for EAHAD in the European Haemophilia Consortium, WFH, ISTH. So I think this kind of collaborative research and registries that we are talking about is possible and doable because we have a lot of advocates and support, and I think we just need to talk about it and brainstorm each other, and hopefully next time we're here we have you know, more data to support what we say and support the service.
I think you're absolutely right. I think there has been a huge development the last years, and there's also a momentum to keep that rolling, just to see that we actually do have been able to define some principles of care that seemed unachievable almost 10 years ago. So it's a huge change that is happening, and yes, and I almost see data coming out which is shocking when we talk about some of the surveys, when we talk about the access to gynecologists, for example, which is known to be an issue that should have been dealt with for many, many years ago. It's still shocking that less than 50% of the treatment centers we talk to actually do have a dedicated gynecologist. That shows us at least there is some work to be done in the future. So maybe we are getting closer to finishing off. We still have about 10 minutes left, but maybe keep looking a little bit into the future. So Dr. Karin van Galen, if I could ask you, where do you see we are in 5 years' time in terms of these principles of care? Do you see them alive around everywhere, coming into your newsletters, or how do you see this developing from here?
Well, I hope in 5 years that these principles of care have been sort of basis also for to get the quality higher in haemophilia treatment centers, and that it can really be used also in audits, that patient care is guaranteed, that women with bleeding disorders also get the care that they need. So that would be very good if that could happen, and also that we are much further in our research, that it's at a level that we can really investigate what makes life better of women and girls with bleeding disorders. And now we are just still at a very, you know, like a desert. It's like a desert. We start from a desert. We have to start to gain the data now and have registration, proper registration. That's the main focus for the coming 5 years, I think.
Maybe Dr. Michelle Lavin, if you want to look into the future.
I would be so excited if in 5 years' time, like I'm actually setting a pretty low threshold here, if we could survey all the centres and find out that every centre had a combined obstetric gynecology clinic with their haematology service and had an algorithm for the management of acute heavy menstrual bleeding, like that is just so shocking to think that, you know, there isn't a centre in Europe, if a man went in with a hemarthrosis, that wouldn't be able to manage that straight away or have an algorithm and a plan that would be standardized. You know, I'm sure of that. But the fact that a woman can go in with heavy menstrual bleeding, and as I always say, my favorite question is ask your colleagues, where do you keep the sanitary pads? And they'll tell you where the factor concentrate is or where the physiotherapist's office is, but the menstrual products, nobody knows where they are, you know. So that just highlights on a very simple level the disparities that women face in care. So if we had access to a heavy menstrual bleeding plan for women and a combined clinic, I think that'd be great. But I know that there's such a focus on gynecological bleeding, and I don't want people to think that we haven't considered the other problems that women face. And certainly in the survey that was sent out, there was a lot of women who reported joint bleeds. And I don't think there's necessary equitable access to physiotherapy for women in the same way that there would be for men, because we're just not thinking about the fact that a woman can have a joint bleed in the same way as if a man presents. So, we are aware that it's not just female-specific bleeding that women experience. It can be post-dental bleeding, it can be nosebleeds, all those other bleeds. But if we can be in a position where care is improved in 5 years' time for women, particularly around the area of heavy menstrual bleeding, which is, we know, the most commonly reported and the most severe bleeding issue for most women, I would be just very thankful and grateful to the entire network for putting the effort in.
Yes, I completely agree. And it would be interesting to make the baseline now, so we can actually see that. Maybe, Deborah, do you have any point of view on this? Where do you see it in 5 years' time? Maybe also in terms of the level of education around. Would that be possible to measure, and how would we measure that, for example?
So I think you won't be surprised to hear me say that I think there's a lot to be done still on quality of life. And it would be very good to explore that. I'm not a great believer in the current quantitative tools that are available for quality of life measurement. I don't think that they capture the lived experience, and that there's some really good qualitative work that could be done. So that's one thing. But where do I see it in 5 years? I think this is the closest the community has been to being together. Everybody's already listed, all of the organisations are on board talking about women with bleeding disorders. And as Rezan said, it felt for a very long time, there was Peter Coidi's group in North America, and Andrew James and Rezan and I, and perhaps some Australian and New Zealand colleagues. And it has grown, and it's so fantastic that everybody is coming together. And I think that will drive it forward. There is enthusiasm from clinicians and from patients and from patient groups. And I think with all of that together, we must be able to continue to drive it forward. Yeah.
Thank you very much for that. I think that's also an excellent way to finish our talks today. I want to start to thank you, the whole working group behind these principles of care, for their dedication. Most of you are here today. Thank you very much for all the time, energy, and all your knowledge that you put into this. This has been absolutely amazing to be a part of. Thank you very much, everyone who have joined today. Has been raising a lot of questions. I didn't even get through half of them, I think. Thank you very much for that. It was excellent to see, and we'll keep the questions and maybe see if we can answer them in a different way, but also just help enlighten us in our finishing off these the principles of care. And I also want to welcome you to, obviously, when the principles out, come back to us with feedback. We really want this to move. If you see something should be changed in a year and 2 years' time, don't hesitate to come back to the working group, to EAHAD, with your feedback, so we can see that maybe we need to make some changes over the time as we all get to know more about what is happening and how they work in real life settings. And with that, I actually just want to say thank you, everyone, and enjoy your evening and afternoon everywhere around. Thank you for today.